Every day, a large number of people, both children and adults, experience medical intervention and care at Triple M. They walk in through the doors of Triple M as patients and walk out with a new lease on life. The Madras Medical Mission Hospital, since 1987, has been synonymous with excellence in patient care and quality medical treatment at an affordable cost. And it continues to draw a large number of patients from various stratas of the society. The Institute of Cardiovascular Diseases, ICVD, at Triple M has many firsts to its credit, including the first adult and pediatric heart transplantation in the private sector, percutaneous pulmonary valve implantation, first bilateral lung transplantation, first Ross procedures, first Batista procedure, and so on. The Institute is made up of several departments, including departments for adult and pediatric cardiology and surgery, and a department cardiac rehabilitation. It is also home to some of the finest cardiac specialists in India. The catheterization lab at the Cardiovascular Diseases Department is a state-of-the-art facility that brings in a multidisciplinary team of doctors. It is here that diagnostic angiographic procedures and therapeutic interventional procedures are performed. With every surgery performed, with every patient treated, the Cardiovascular Diseases Department at Triple M reinforces its commitment to its missionary values. Every patient that comes in for treatment at the department, from a day-old baby to a 90-year-old, is an opportunity to further the Madras Medical Mission's goal of reaching out to the unreached.
Good morning. I am Dr. Shivakumar from the Madras Medical Mission, Chennai, India. And we will be seeing today a patient who presented with a cardioembolic stroke. During the course of evaluation, he was identified to have rheumatic severe mitral stenosis. Even though he was in sinus rhythm at the time of clinical examination, we don't know whether he had episodes of atrial fibrillation. So we will be presenting a brief clinical history followed by the procedure. And to assist me is Dr. Ashok and brother Dilip Kumar, who is scrub nurse. The cath lab technologists are Mr. Prabhu, and I have an imaging expert, Dr. Pramod Sagar, who usually assists me, and he'll be performing an online trans-esophageal echocardiogram for this patient. Over to you, Anselin. Anselin will be presenting the clinical story of this patient. This is for what? I want ACT.
Normal sinus rhythm with a heart rate of around 60 per minute. The left atrial enlargement is there with normal ventricular forces. Chest X-ray shows a dilated left atrial appendage with features of pulmonary venous hypertension. The transesophageal echocardiogram shows restricted mobility of the mitral valve leaflets with a narrowed orifice. There is severe mitral stenosis with a 2D mitral valve area of 0.9 square centimeter with a gradient of 16 millimeters of mercury, a mean gradient of 7 millimeters of mercury at a heart rate of 70 per minute. This is the 3D zoom image of the mitral valve showing the narrowed orifice of the mitral valve. This transesophageal echocardiogram image shows a dilated left atrium and with spontaneous echo contrast and a small thrombus at the apex of the left atrial appendage. This is the 3D zoom image of the left atrial appendage. Thank you.
Oh, thank you, Dr. Anselin. That was a wonderful presentation. So what you are explained is a 48-year-old gentleman who primarily presented with a stroke, and during the course of evaluation, you found that he had all clinical features of severe mitral stenosis, which you described as opening snap, mid-diastolic murmur, and a pre-systolic accentuation. And you showed lovely echocardiographic images where there was a left atrial appendage apical thrombus. So now the question of management of this mitral valve will be whether to do a valvotomy or to go for a valve replacement. It's very obvious that you were showing data which was echocardiographic data which shows that the valve is quite pliable. But let me listen from the imaging expert, Dr. Pramod Sagar, who has done a transesophageal echocardiogram right now in this patient, and probably he will be able to explain the characteristics of the mitral valve, and probably he will touch on the Wilkins and Weyman score also. Over to you, Pramod.
Good morning, everyone. I'm showing the transesophageal images. I hope everyone is able to see it. See, this is the 0 degree where we are seeing the 4 chambers of the heart, and this is the mitral valve. As we all know that we saw in the presentation that the mitral valve was thickened and it was having significant stenosis. Now I will describe this valve in various components which are very important for selection for a balloon mitral valvotomy. The first one is the thickness. You can see the thickness of the valve. I have zoomed it. In the zoomed image, you can see this is the ATL and this is the PTL. And we can see that the tip of the PTL is quite thickened. The ATL is also minimally thickened throughout. If you objectively measure it, the PTL actually was measuring around 4.5 and the ATL,
Anterior mitral leaflet.
The PML was measuring around 4.5 and the AML was measuring around 3 to 4 millimeters. So it is minimal thickening, but it is definitely thickened. And if you want to see the mobility, the second component, we can see here that this is the AML. This is in a 120. This is in a 120 degree, nearly a 120 degree view, where we can see that this is the ATL. This is the anterior mitral leaflet, which is well mobile. Actually, even the mid part and the basal part of the AML is quite having a very good mobility. The PML mobility is a bit restricted, but we can see that the mid belly of the PML also is having some amount of mobility. So the mobility is minimally restricted, but it is not too much terrible. It's a good mobility of the valve leaflets, which says that the valve is pliable. Again, in the same view, in the zoomed image, you can see the mobility of the AML, and the AML is very good and the PML is restricted, but it also has some amount of mobility in the mid and the basal part. So the third component, if I want to say, is the calcification. Here I will freeze some images and I will show you. Here we can see that there is specks of calcification in the tip of the PML, some amount of calcification here, but the whole leaflet is not calcified. It's just the localized areas of calcification, which again makes it a better valve for a balloon mitral valvotomy. The next component would be a commissure. This is actually in the upper part of the, I have imaged this in the superior part. So this is the anterolateral commissure. Actually, this region is the anterolateral commissure, where we see there is fusion but no calcification. And this is actually, when I push it downward, actually, this is the posteromedial commissure, which is also not having calcification. I will show the commissure better in a 3D view. And again, if you see the fourth component, that is the subvalvular apparatus. This is the region of the subvalvular apparatus. Here we can see. I will freeze it and show again. This is the region of subvalvular apparatus from here to here. This is from the PTL. This is region of AML. From PML, and this is the region of anterior mitral leaflet. Here we can see that we can't see it well in the anterior mitral leaflet region. It means it is not really having much of a calcification, much of fusion here. But here when we see, there is fusion of cardia, and the cardia is bit thickened. So there is minimal subvalvular thickening, and the subvalvular thickening also is not very prominent. The fifth component I would show is the amount of mitral regurgitation. Here we can see the color image which shows significant flow turbulence with flow convergence in the region of the mitral orifice, but there is no significant mitral regurgitation at all. I would say there is no mitral regurgitation. And this is in another view again to show that there is no significant mitral regurgitation. So as I told earlier, I would show a better commissural anatomy in a 3D view. This is a 3D on-first view of the mitral valve from the left atrial surface. This is the region of the anterior mitral leaflet, and this is the broad posterior mitral leaflet. This is the anterolateral commissure, and this is the posterolateral commissure. I will freeze and show once. So if you move now, if I move it, we can see the opening and closure of the valve, and the commissures are fused. The commissures are fused here, but there is no significant calcification there. Now I'll show one more image. This is the view from the left ventricular surface. Here we see again the valve is quite stenotic with a fish mouth orifice that we can see here. And when I measured it, the mitral valve the area by planimetry in a 3D was around 0.8 centimeter square, which is very severe mitral stenosis. So if you see the gradient, this was in a patient who was intubated and was having significant sedation. So the gradients were not very high. The maximum P gradient was 15 with a mean gradient of 7. Other than these 5 components, the other things we have to see in the mitral before doing a BMV is presence of a clot. Here we can see that this is an image which shows the LA is quite significantly dilated, and we can see a lot of spontaneous echo contrast in this patient. This is a spontaneous echo contrast, and we can see so much of contrast that is seen during the study. And this is the left atrial appendage. Again, here you can see a lot of spontaneous echo contrast. A possibility of a layered thrombus is seen here. I am showing another image here. If you see the apex of the valve, apex of the appendage, here it looks like there is possibly a small amount of thrombus, which I will show in a frozen image again. This is the frozen image, which shows possibly there is a small LA appendage apical clot. So if you see the velocities, the appendage velocity is around 0.2, more than 0.2. It's not very bad, but it shows that the atrial appendage function is good. And the other component we have to see is the atrial septum, because we have to do a puncture. Here we can see this is the 0-degree view, and this is the 90-degree view. This is a thinner atrial septum in the fossa ovalis region. Here in the 90-degree, we can see that there is possibly a flap which was not having any color flows, so it would be easier for us to directly go and puncture here. Yeah, about the LA appendage clot, we will discuss about when we can do a BMV in a patient with LA appendage clot in the part of discussion over some time. But however, I feel that based on these 5 components, we can't score in any, though most of the scores are based on all these components, not all scores have all the components, and that is the drawback of all these scores. So thank you
very much, Pramod. I think you had illustrated nicely. So what you showed was that there was a thickening of both the anterior and the posterior mitral leaflets to around 4 millimeters. The second thing that you showed was the tips of the anterior mitral leaflet as well as the mid portion and tips of the posterior mitral leaflet have restricted mobility. You showed small specks of calcification but not quite extensive, and you showed moderate subvalvular shortening, and there was a left atrial appendage thrombus. As you rightly mentioned, the discussion will be whether to put in the patient for an open mitral valvotomy, which is on a cardiopulmonary bypass, if we have a strong fear of a left atrial appendage thrombus. The second one will be a balloon mitral valvotomy without engaging the left atrial appendage during the process of catheter manipulations. So what was done in this patient was that he was put on 6 weeks intensive anticoagulation. So he received Coumadin to maintain an international normalized ratio of prothrombin time more than 2.5 for almost a period of 6 weeks, and then he's brought into the cath lab today. The initial part of the hemodynamics, as I show you right now, we have a catheter in the aortic root on the non-coronary cusp, a pigtail, and a diagnostic end-hole catheter in the main pulmonary artery. The main pulmonary artery pressures are around 35 millimeters systolic with a diastolic of around 15 and a mean pressure of close to 22 to 23, showing mild pulmonary hypertension. Now we have to, as Pramod stressed, this is a patient who is under anesthesia, and so some of the hemodynamics will slightly be lower. The aortic pressure from the central aorta is about 120 over 80. And this patient is basically being anesthetized and maintained on a small dose of dexmedetomidine plus propofol sedation by Dr. Uday. Uday is our senior cardiac intensivist. So now the next step will be to go in for a septal puncture. So as a process of septal puncture, we will be now withdrawing this pulmonary artery catheter from the PA. We come into the right ventricle now. This is the right ventricular pressure. The right ventricular pressure is close to about 35 millimeters of mercury. This is the right atrial pressure. Right atrial pressure is a mean of around 9 to 10 millimeters of mercury. Now we advance this catheter into the superior vena cava and go into the innominate vein.
While you are doing the procedure, may I ask a question, sir?
Yes.
So what is the site of septal puncture that you plan for balloon mitral valvotomy?
In general, it will be in the middle of the fossa valis or antero-inferiorly, the closer to the mitral valve. So in certain indications, the septal puncture will be in different locations. For example, when we are trying to do a left atrial appendage device closure, we will be taking the puncture very posteriorly and inferiorly. Similarly, when we are trying to do a mitral valve-in-valve implantation, a transcatheter mitral valve implantation, we will be doing postero-inferiorly. For procedures like mitra clip, it will be postero-superiorly. Now, this is a 8 French Mullin sheath. This 8 French Mullin sheath is now passed on this 035 Termo wire. We go into the left innominate vein. So already the guide wire is in the left innominate vein, and Dr. Ashok is now advancing this Mullin's dilator into the left innominate vein. Once we go into the left innominate vein, this wire comes out. So once I get a good backflow, I next take up the BRK needle. This is a BRK needle with a 45-degree angle, and this needle goes now through the Mullin's dilator. As I am passing it, it's being tracked on fluoroscopy. So it crosses the sacral promontory, it goes through the inferior vena cava, it enters the heart, it goes through the superior vena cava, and it reaches the tip of the needle, tip of the dilator. We have connected a contrast syringe. So right now I'm going to come down live on transesophageal echocardiography on X-plane. So we are coming down on X-plane. I'm bringing it down. We are now entering into the region of the fossa valis, making a gentle indentation of the septum. And now Pramod will rotate right and leftward to see the place where my puncture is. If you get the X-plane onto the needle, then yeah. So I'm making much more indentation to find out.
Here there is a mild indentation that is seen here.
Yeah. Now
Minimal
can you rotate
indentation
and
is
show
seen
me
here.
on? Yeah. I'll probably bring down the right now. Can you show
Right
me the
now,
place of my indentation?
no, it is seen here already. It's in that. Yeah, it seems it's already. It's at the region of. It seems it is here at the region of this
Okay. So
fossa
now
ovalis, like on
on.
the superior part of the fossa ovalis.
Okay. I'll make a rightward torque. Again now making. I'm staining the septum now.
Yes, sir. You can see here the contrast is still in the filling the right atrium, and it is at the level of fossa ovalis.
Okay.
Yeah, here.
Is now can you show
Yeah,
me?
the indentation is seen here now. Well, it is stunting. It seems it's indenting nicely.
Okay.
Here we can see the indentation.
So we
is
can see
happening.
that
It's
we are
already punctured, and the contrast is in the left atrium.
correct.
Here we can see the puncture site.
Okay. So at this position, I take out the needle and connect the needle and connect the Mullin sheath to pressure to document the left atrial pressure. And at the same time advance the pigtail catheter into the left ventricle to record the transmitral gradient. We'll use a wire for entry from aorta into the left ventricle. So now we have the catheter, one catheter in the left ventricle and one catheter in the left atrium to document simultaneous LA, LV pressure in the same scales. We'll analyze the wave patterns. The LV also now will go to 20 scale. And now increase the speed, please. Yeah. So we can appreciate that there is a atrial, the A waves are tall, the V is small, and we have a transmitral gradient that is seen throughout from the beginning of the diastole to the end of the diastole. The patient's heart rate is just about 50 to 60. It's a very slow heart rate, partly due to the beta blocker that the patient was taking and partly due to the deeper level of anesthesia. So we have the left atrial mean pressure of around 16 to 17 millimeters of mercury. Dr. Pramod showed the mitral valve area to be about 0.8 square centimeter, 0.8 to 0.9 square centimeter. The next step in this procedure will be we advance this pigtail wire. The pigtail wire is actually a stainless steel wire. So the stainless steel wire now goes through this Mullin's dilator. And when we are advancing this, we have to ensure that we don't enter the left atrial appendage. So we are advancing the pigtail wire, fluorostore this in such a way that we don't engage. Show this picture again. So we don't engage the left atrial appendage at all. So at this point of time, the venous sheath that has been placed previously in the femoral vein is removed. So this is the pigtail wire that is going in. We ensure that there is no entry into the left atrial appendage. The next step will be advancing a 14 French dilator This dilator has got a twin job of dilating the groin to facilitate the balloon entry and dilating the intraatrial septum. So we are advancing the 14 French long dilator. So this dilator now goes in and is going to dilate the septum. Can we see the septum?
Yes, sir.
Where it is?
Sure.
So this is the dilatation of the septum that is happening. So what we do is pass this dilator 4 or 5 times across the intraatrial septum in order to facilitate the balloon entry subsequently. I want a small artery forceps, a mosquito forceps, to dilate the groin. Yeah. So the next step will be balloon. So now we'll look at the balloon. I hope you are able to see the balloon now. This is like an Inouye balloon. This balloon is called SYM, S-Y-M. This is similar in construction to the Inouye balloon made by the Toray Corporation, Japan. It has got a latex balloon with a fabric. The fabric is peculiarly placed in such a way that when I make the initial inflation, it is always the distal part that inflates first. So this engages the left ventricular side of the mitral valve. As I inflate further, the proximal part inflates next. So this engages the left atrial part of the mitral valve. And as I inflate further, slowly the waist expands and the waist now gets the mitral valve at the commissural level. Now, the way to fix the mitral valve diameter will be based on the height of the patient. So in general, the thought process is the taller the patient, the larger the mitral valve area should be. So this is a patient who is about 170 plus centimeters. So the rule is height in centimeter divided by 10 plus 10. So 170 divided by 10 will be 17, plus 10 will be 27. So we put a caliper to see whether we are somewhere around 27 millimeter. So I have planned it in such a way that this is 27 millimeter. I hope you are able to see the image. So it's a 27 millimeter middle waist. So now I'm deflating the balloon. This balloon has got a larger profile. So in order to reduce the profile, we have got a slenderizing tube. So this is the slenderizing tube. It's a stainless steel tube. And as I push the slenderizing tube, you will appreciate that the tip of the valve is straightened and elongated. So now this balloon got elongated in this process. So this is elongated to around 14 French. So this completes the preparation of this balloon. So right now we are going to take out this dilator. So the dilator is out now. A small mosquito forceps spreads out the tissues. Put the balloon inside. Yeah.
So will you always follow this Hunk's formula, that is the calculation for determining the size? When
In
will
general,
you think about downsizing if you are doing a BMB in some specific situations?
Correct. That's a good question. If suppose the patient is having a high risk valve, such as a valve that is showing significant calcification, a valve that is showing marked subvalvular fusion, so where you suspect that a mitral regurgitation will not be tolerated at all, you tend to undersize. Now, two ways in which it can be done. Number one is you load the balloon with a lesser amount of contrast, so that you don't end up in too much of stretching. The second way in which it can be done is, fluorostore this. The second way in which it can be done is, as you are inflating, titrate your inflation in such a way that you don't inflate to the full volume. So now I am shortening the balloon. So the balloon has been made shorten, and I'm removing this pigtail. Can you take this out, please? Take it out. So the moment this is taken out, I'm again flushing the INUI balloon so that the lumen is free of thrombus. At each step, in a patient who is having a left atrial appendage thrombus, we try not to enter into the left atrial appendage at all. So now we have flushed. I'm again checking the left atrial pressure here, because very accidentally, if I go out into the transverse sinus by a very anterior puncture, so that I'm very close to the aorta and my balloon goes into the transverse sinus, this is a time at which I can pick up. I am not in the left atrial cavity. Now again, you are able to see that the left atrial pressure is about 17 millimeters, 16 to 17 millimeters of mercury with a tall A waves. So we confirm that we are in the left atrial appendage. The next step will be using this directing stillet. The stillet is planned in such a way that it has got a 180-degree turn and it marginally faces anteriorly. If you look here, this is marginally faces anteriorly. So in fact, it is meant for directing this balloon more anteriorly. I have given more anterior like a tilt, so that it actually goes more anteriorly and engages the mitral valve. At this point, what I do is I take up this directing stillet through this mitral valve and I go into the valve, the balloon. So now I have got the stillet reaching the tip of the valve. At this point, I go to right anterior oblique view, and in that right anterior, basically the purpose of making it right anterior oblique contrast is to get the entire long axis of the left ventricle. So here we are using a right anterior oblique view and making a left ventricular angiogram just to localize the mitral valve. So that is the mitral valve. So after visualizing the mitral valve, this stillet is given a marked counterclockwise loop so that it faces the mitral valve, and slowly I keep coming down. And as I come down, the balloon should start facing the mitral valve. Show the angiogram once again. We'll relook at the location of the mitral valve. Okay.
Yes.
So it is briefly entering the mitral valve.
The tip actually is at the mouth, but it's not going in.
Yeah. So I have to wait for the diastolic opening, and at that time advance.
Yeah.
So now we fluorostore this and show this entry. So now there are some ectopics that has been produced by the tip of the mitral valve. So here you will appreciate that towards the mitral valve, the tip of the balloon mitral valve, the balloon was entering into the left ventricle at this point, and then we make it slightly straighter by bringing down the valve, the balloon, and then engaging deeply inside so that it reaches the tip. So now the next step will be to ensure that it has gone free and there is no restriction. So once we have identified that there is no restriction, the next step will be we make the distal dilatation, pull back and engage the valve. Now we go for the proximal dilatation and the whole balloon came off. So basically what is if the valve is sort of pliable, let us see what was the amount of valve opening. Can you put the
Yes, sir.
Doppler now? Put the Doppler now. Color Doppler. Color Doppler. Yeah, it's probably some amount of opening is there. There is a little reduction, but what we'll try to do is engage the valve a little better so that the balloon is facing inferiorly here. So we have to face towards the valve. I'll give a little bit of inflation so that the balloon floats in. There are times at which it faces, but the tip is, yeah. I'll reduce the curvature on the stillet a little bit. I will aspirate the blood and flush with saline. And slightly open out the stillet. So I have opened the stillet a little bit now. It's entering the mitral inflow. However, the balloon is facing too inferiorly. I'll give a little bit more inflation. And again try now. I'll probably take off that inflation and reduce the curvature a little bit more. Again, aspirate and flush it out.
What do you think is the difficulty? What is the reason for this difficulty in this case?
The probably the puncture was a little bit more away from the mitral valve.
Probably a bit higher.
Yeah. It enters, but comes at an angle. See, at that point it's facing.
Faces. Yeah.
It was facing more towards the anterolateral commissure. So at this point, I will little bit increase the volume of the balloon. Dilate the distal part. Now come up to the proximal. It's just coming out. It's a very elastic valve. Okay, now what we'll do is we'll dilate, so engaging the valve.
No, it's again comes up.
Yeah, it's the problem is that it was too elastic. So it is. Hold it here. It's popping out. When the valve is very elastic and what might sometimes happen will be a ventricular ectopic will make a forcible contraction in the post-ectopic beat. Hold it. Okay. Fluorostore this last one. I think the valve is looking a little larger.
Looks a bit.
Can
Opening
you?
looks a bit better. We'll
Yeah.
see once again.
I will aspirate the blood, connect it to pressures.
It is more laminar when compared to earlier.
Yeah,
It's not much turbulent now.
yeah,
There's no MR again.
I agree
Very
with you.
trivial MR maybe. Too much.
Yeah, I don't find a significant MR. So here in the hemodynamic trace, the gradient between the left atrium and the left ventricle has gone.
It was a really very too pliable valve. It just was the probably it was too pliable. That was the
Yeah,
reason that it was just coming off, and probably the commissural.
yeah, there is not much of a gradient
Normal.
now that we are seeing. Can you Doppler
Yes,
and
sir.
then get a Doppler trace, pulse wave Doppler?
Oh, yeah. Yeah, this is
Can you freeze it and then measure? Yeah,
this is a pulse wave Doppler.
yeah.
Here we can
It's
see
not
that
crossing
we
1
are
meter
getting
per second.
it's not too. It is looking good actually. It's like
this
just
is a
mean of just less
2
than
millimeters of, yeah, we are
Less
in the
than 2 mean.
hemodynamic trace also. I'm finding just around 2 millimeters of mercury. It's a 20 scale. Through in the middle of diastole, where there is diastasis, it looks like the left atrial and left ventricular pressure curves are touching each other. Towards the early diastole and towards the late diastole during atrial systole, there is a small pressure difference that is seen. And can you, yeah, definitely the 3D echocardiogram shows the valve area is, yeah, the ventricular surface was looking very good.
Yeah. No, this is. One second, I'll just
Yeah.
get a better image.
So I think I'm happy with the dilatation. So the next step will be
Yeah.
I take out the tube. So I again go back with the slenderizing tube and go into the mitral valve.
Yeah, the opening looks good now.
We again ensure that we don't enter the left atrial appendage. So I have slenderized the tube, I have elongated the balloon, and I'm taking this out. Yeah, the valve looks very
Good,
nice and
actually.
wide open.
Valve is nicely open. I'll just try to measure it.
Get me that 9 French. short sheath. Get me a right coronary artery catheter. Hold the wire. So the catheter is now in the left atrium, and we are taking a direct left atrial and left ventricular pressure. Can you come to AP view, please? Yeah, definitely the valve looks wide open. Wide open.
Opening is good now.
Just open the valve now.
Yeah,
I think
just,
in the
I'll
scroll.
unfreeze and show this.
Yeah,
Yeah,
it's
the valve opening is good.
yeah. I think
It's from the ventricular surface.
Yeah.
The valve opening is very
so
good.
this is the
Very
left
good.
atrial and left ventricular simultaneous trace. There is hardly around 2 millimeters of mercury pressure difference throughout the entire diastole. So now from the left atrium, which is showing a mean pressure of around 13 millimeters of mercury, I am pulling it back to right atrium. And the right atrial pressure now is about 10 millimeters of mercury. Wire, please.
The posterior medial commissure looks very good, very well opened actually. The posterior medial commissure is well opened actually.
Okay.
And we can see that there's a good opening of the valve even from this LA side. The
Okay.
valve opening is very good.
Okay. Okay, the problem of this mitral stenosis is unique to certain countries. Can you hold the wire, please? It's a disease largely seen in the developing countries. However, there is a resurgence of rheumatic fever and rheumatic heart disease in some countries such as New Zealand, Australia, Hawaii Islands. And so now this is the pulmonary artery pressure and the simultaneous aortic pressure. So let us compare the that's the pulmonary artery pressure. The pulmonary artery pressure now has come to a mean of around 20 millimeters of mercury. So there was a very mild elevation of the PA pressures prior to the procedure. Now it is mean of 20, which is just at the upper limit of normal. And the aortic pressure is about 120 over 77. Put it in 100 scale. Yeah. So that is the aortic pressure. So now I will give it to you to show the echo in all details.
Yes.
Being an adult patient, I'll just shoot his coronary angiogram just to ensure that he doesn't have any coronary atherosclerotic heart disease. Now you can keep showing the echo, Pramod.
Now we can see this is the post-procedural echocardiogram. This is a T of at the 0 degree. Now we can see the leaflet mobility is the leaflet opening is fairly better when compared to the baseline that we are showing. The AML and the separation between the tip of AML and PML is quite well. You can see the separation is better when compared to earlier. We'll just try to explain and show that again in some other view. This is actually this is something like a 120 degree on the left side of the screen, again, which shows that the leaflets are quite well separated. The separation of the tips is good actually. And again, if you see the color, nearly laminar flows, except for some degree of trivial regurgitation that is seen at this commissural region. On the right side, there is no much of regurgitation. The flows are nearly laminar. This is you can see here actually on the right side of the screen, it is a bicommissural view where we can see that the right side, this is the anterior commissure is having some amount of leak there. Otherwise, the commissural, other than there is no significant leak, and it is almost a laminar flow actually. And we saw the gradient, it was like less than 2, and
Can you show the intraatrial septal puncture also and see whether that atrial septal puncture needs any intervention?
Just see it again. Yeah, this was the site of the puncture. This was the site of the puncture. We can see here that.
Is there any
no,
color flow across?
Yeah, I'll just put it. But like by 2D, I can't see any definite region there. And here we can see there is a small color flow. On the right side of the screen, we can see that there is a minimal color flow across that septal puncture site. That's also not looking very large. So unlikely that it requires anything for that. You can see this is a very small orifice actually. A small orifice with
Yeah. So it's hardly of any significance, right?
Yes, sir.
So thank you, Pramod. I think it was a wonderful demonstration of echocardiography. What we found was a rheumatic mitral stenosis which presented with a cardioembolic stroke and a left atrial appendage thrombus. On adequate anticoagulation, 6 weeks later, taken up for a balloon mitral valvotomy. The valve was probably very pliable and was very accommodative, that the balloon was 3-4 times slipping out as we were trying to position the balloon. And during the last attempt, what we did was we did not give a traction. Can you just show that last one balloon dilatation sequence alone, the final balloon, which probably is quite educative. I think this is the last sequence. Here you identify that basically the valve is now popping into the mitral valve, and at diastolic frame, when the valve is open, we are advancing the balloon deep inside the left ventricle, and once it is inside the left ventricle, it is inflated and it is brought back to the region of the mitral valve, and no pull is being given at all. No, absolutely no pull. And you inflate the valve to the maximum diameter. And in spite of that, still the balloon pops off, because the left ventricular contractility will try to push out the balloon if the valve is very pliable. And now on transesophageal echo, you find that the valve is nicely open, and the gradients have come down to less than 2 millimeters of mercury. So it's a rewarding result, and I thank the opportunity. We probably will come back next week with yet another very interesting intervention. Until then, goodbye from Madras Medical Mission, Chennai, India.